So without further ado, tonight I'm very excited to welcome Damon Tweedy, celebrating the release of his new book, Facing the Unseen, The Struggle to Center Mental Health in Medicine. Damon Tweedy is a professor of psychiatry at Duke University School of Medicine and staff physician at the Durham Veteran Affairs Health System. His first book, Black Man in a White Coat, was a New York Times bestseller, selected by Time magazine as one of the top 10 nonfiction books of that year. He has also published articles about race, medicine, and mental health in medical journals and print publications, including the New York Times and the Washington Post. Tweedy will be in conversation with Dinah Miller, a psychiatrist and writer in Baltimore, Maryland. She's been a longtime blogger, a columnist for Clinical Psychiatry News and Medscape, and is the co-author of 2 nonfiction books, Shrink Wrap, 3 Psychiatrists Explain Their Work, and Committed, The Battle Over Involuntary Psychiatric Care. She is the former president of the Maryland Psychiatric Society and is on faculty at Johns Hopkins School of Medicine. Please join me in welcoming to Politics and Prose, Damon Tweedy and Dinah Miller.
So did Lily introduce us?
Yeah.
Okay.
Yeah. So first of all, I just want to say, thanks to Politics and Prose for hosting this. Thanks for C-SPAN for filming, and thanks for you guys for coming. It's Friday night in DC. There's obviously a lot of other things you can do. So really, thank you for coming out today. Really appreciate it. And thank you. So Dr. Miller actually is someone. She's a fellow writer, doctor, psychiatrist, and really kind of helped inspire some of my writing as well, particularly on the topic of psychiatry. So thank you as well.
Thank you for having me. I'm excited to be here. And so, Damon, I've read both of your books, and I want to say that I read some of Facing the Unseen while it was in progress. And I just wanted to congratulate you because I know you asked for my opinion at times, and I'm not always the easiest critic. And so when the book came and I started reading it, I was like, wow, this fell together really nicely. So I just want to congratulate you on what a great job you did putting it all together. I was impressed in reading it that your ambivalence about psychiatry, especially as a med student, as a young doctor, mirrors society's ambivalence about psychiatry. Like, I really had the sense from this that making this decision to change from medicine with a goal to go into cardiology was hard for you. And in fact, in times reading the book, I felt like it wasn't just hard, it was a little bit embarrassing. That you talked with a psychiatrist about maybe changing fields, and it was a big hush-hush secret in a way that I don't think it would have been if your thought was, oh maybe I don't want to be a cardiologist, maybe I want to be an infectious disease doctor.
Right.
But it didn't have that feel. It was like, oh my gosh, maybe I want to be a psychiatrist. So I'd love to hear about what you felt about psychiatry or what you knew about it growing up, and how you got over that hump of, I'm afraid to tell people I want to become a psychiatrist.
Yeah. So it's great. Great we're in DC because this is kind of my home stomping grounds, DMV. And when I think about DC, I think about my grandmother. So my grandmother, on my mom's side, lived in DC, and she lived on Northeast and Georgia Avenue. And as growing up as a kid, we would come visit her after church on Sundays. I get dragged to church and we come visit my grandmother. And in some ways, she was my first introduction to a lot of things about life, but also about medicine, about race, and about mental health, although I didn't even really understand it at the time. Because my grandmother was someone who's very, what you might call high energy, very demonstrative. She was like a chain smoker, and she would pace around a lot. And she would talk about how she had to be that way. She had to be strong, like a strong, black woman. She talked about her history and all the things that she had faced in her life. But there was never any sense, that at least that I could understand, at the time that, she suffers from something that would be considered, we may now call like anxiety or some sort of mental health problem. It was never framed that way in my family, in the way that I grew up. If anything, my family members, one time someone suggested she might talk to someone, and she's like, well, why would I go and talk to some stranger about some problem? How are they going to help me, right? And so it was just like really dismissive. And so I think one of the things that's really, you mentioned other medical fields. And so psychiatry, I think people actually come to medical school in psychiatry in a very, but often with even preconceived kind of negative thoughts about the field in a way that they wouldn't for something else. So like you think about people with mental health problems, and we think often about people who are homeless and maybe talking to themselves on the side of the road, or people who have struggled with addiction and all the complications that can cause. And we come to med school with this idea that maybe those are people that they're maybe difficult and people you may not want to sort of that was sort of the may I want to sort of handle, deal with. It may be difficult, right? And so, whereas you think about cardiology, you're doing these procedures, you're saving someone from a heart attack, you're saving their life. There's sort of this kind of heroic quality to it. Orthopedic surgery, someone has a broken hip and you fix them and they can go out and start functioning. I think psychiatry had a very different sort of sort of awareness to it, and I undoubtedly brought that to me when I got to medical school, and it almost got worse because, so my psychiatry rotation, I think, actually sort of just made that, perpetuated the problem. You think about my surgery rotations in medical school, surgery, OBGYN, peds. You're in the hospital, you're in the main place attached to your main place where you train. For my psychiatry rotation, we had to go 30 minutes away to like a state hospital, and you had to drive, to a different county, cross county lines. And I remember getting off that first day on the highway, and there's you see a sign for a federal prison, and then you see a sign for a juvenile detention facility, and then you get to the psych facility, and there's like this idea that it's separate and different and distinct, and so all those things really kind of, I think, really fed on this idea that psychiatry was kind of scary in some sort of way. And I will have more to talk about, like, what I think we can do about that, because I think I have a lot of thoughts about how we can make that better. But that was my initial impression and my initial kind of introduction to psychiatry. So psychiatry was not something that I was attracted to. And I'll just tell you, just because it really is a long road for me to get to where I'm at today. Psychiatry didn't want me either. So no, I did not. So I did this rotation.
They're sorry about that. They want you now.
So in this rotation, at the end of this first rotation, we had to interview a person that we had never, a patient who was on the ward that I'd never met before. And there was a faculty member like yourself who was observing my interview and making sure I had 30 minutes to do everything right. And as you can tell, I have a tendency to talk fast. And the patient that I was seeing talked very slowly. And in 30-minute time to get all this information, figure out like why is he here, what are his issues, what's the plan, all that sort of stuff that medical students are supposed to do. It didn't go well. I started rushing, cutting him off, answering questions for him. Really bad scenario. And at the end of this session, the faculty member says, well, Damon, what do you want to do with your life? And so that's probably a warning sign. And then I said, well, I'm interested in orthopedic surgery or cardiology. And he said, those are good fields, but you really have to talk to patients even if you do those fields. And given what I just saw, I think you might consider pathology or working in a lab. And so it was really like the opposite of what you would expect. So that was my introduction to psychiatry. So somehow we can talk about how did I get from there to here? Yeah.
Okay, how did you get from there to here?
I just noticed this is I'll tell you, this is actually the first book. Yeah, can we share the other book as well? Thank you. Yeah, we'll get both of them here. Be careful there. It's actually important, I guess, in some ways to talk about that, because I see this book as, in some ways, like not a sequel per se, but as like telling a similar type of trajectory, right? So this first book is really about race in medicine, and really about like talking about a really complex issue with race, of course, and how did my own experience and journey through medicine sort of intersect in that way. This book is really about another difficult issue. Mental health is a really difficult issue for us to talk about, and how did my own experiences with that sort of intersect with the medical training that I sort of undertook. So it's really, there's a very sort of thematic, I'm talking about difficult topics, right? And so how did I get from, cardiology, Damon, because I really loved EKGs. I really thought I was going to be this guy. I know I love reading EKGs and all that.
I'll send you some. Actually, I was impressed that you drove in the book. You drove an EKG 15 minutes away to ask a colleague to look at it, and I thought, oh my gosh, now I'd just snap a picture and text it.
Yeah, this was kind of a little bit pre cell phone day, kind of sort of. But yeah, no. So how did it all kind of come to pass?
I'm gonna text you my EKGs,
and I can still read them. And so I think there are a couple of things that happened. One is I had a friend actually. Because one of the challenges with mental health problems, I think, is that we can sort of separate ourselves from people who have these mental health issues. And I think there's a sort of us versus them kind of separation. You know, that someone we might see who's homeless or struggling in some sort of way, talking to themselves, that we can never be that way, and no one that we care about could ever really be that way. I think there's definitely that sort of disposition. I think that informs a lot of how we do policy and how we treat mental health illness as separate. I think it's a really big deal. And so one day I was going down to the ER I'm a medical intern, so I'm still thinking cardiology at this point. And our goal is to actually, there's a person who's there who's sort of acting strange. And we're supposed to do a medical clearance, which means we're supposed to make sure he doesn't have a brain tumor or some sort of infection or something else that might be causing his behavior. And then I walk in there and I see this as a person that looks familiar. And I just sort of like do this double take. And then it's like, man, that's, so-and-so that I used to know. We used to play basketball together. And my feet were just like planted to the ground. I couldn't move because I'm like, this is the person I'm supposed to evaluate who's acting sort of, in this way that I can't wrap my head around is someone that I knew in a totally different way. I knew him as like me, right? And so it was a really sort of, this eye-opening experience to sort of see that in person. And so that was one thing that kind of really sort of was a really big eye-opener experience. Another thing that kind of happened is there was another time in the ER where I saw there was a woman who would come in and she was basically, we were admitting her to our medical ward because she was frozen. Like she couldn't move, she couldn't talk. But she was, quote, medical because her blood pressure was really high and her heart rate was really high. And so there was this kind of mystery, like what's going on and how is that causing her to have this problem where she can't move or talk? And so we go in there and this shows you, this really illustrates how sort of backwards our systems are. So there was a medical record system, and then there was a mental health record system, and they were totally separate. And so the medical doctors in the ER could not actually access the mental health records. All they could see was the patients. It was like totally, same system, but two totally different systems. And so they paged the psychiatry resident to say, well, what the hell's going on here? Because they wanted to be access to these records to know what was going on. Really, that's just such a just terrible sort of system that we have. And this wasn't just this one hospital that I was at. And so the psychiatry resident sees her, and he pretty quickly he says, I think she has it's catatonia, which is a condition that can cause people to sort of be mute and not move and have medical issues. And he says she needs a treatment called Ativan, which is like a sedative that people take for to help them sleep or for anxiety. So most people it slows them down, but it's actually paradoxical in this case, where it actually was a treatment for this person with catatonia. And so within like an hour or so the ER medical doctors were like really dismissive, like, oh, what does this guy know? He's a psychiatrist, kind of thing. But then it turned out that was actually the definitive treatment, and she started like. In an hour or so, started to move and was trying to talk, and it was amazing. And it turns out he actually probably saved her life. In severe states, this catatonia can progress to acute renal failure and heart, and you can die from that. And so, as a psychiatrist, it was sort of like in this moment, like the heroic kind of thing. And that's not the impression you get from medical school. Psychiatry is seen, and this is kind of the idea of the facing the unseen, because psychiatry, when you go to med school, psychiatry is seen as that field that doesn't have the lab tests, doesn't have the physical exam findings, doesn't have what you might call something that's real or tangible. And that makes us think that psychiatry is somehow, not a real thing, right? But of course, we know mental illness is very real, right? You think about all the issues that people have with addiction, overdose, suicide, very real. But nonetheless, there's this culture in medicine that teaches you that it's not real. So that was an eye-opening moment. And that led to that day you alluded to earlier, where I'm like, so I go up the stairs the next day when she's admitted to the hospital, and I see a psychiatrist. She actually was a medicine psychiatry dual trained. And I said, this case is really interesting. And she's like, are you interested in psychiatry? I was like, no, of course not. I looked around, I can't say that. But I wanted to talk to her more about it. So then I went and closed the door to make sure no one else was around, because there was this idea again that, I went to med school to become an orthopedic surgeon or a cardiologist. I'm from a family. My brother and I, kind of like first generation college, and here we are going to med school, and you can't go to med school and be a psychiatrist. And that was sort of the perception. So it was a really, really hard thing to sort of. You think about my trajectory, how I kind of came from my community, how they saw mental health issues, and how the early med schools saw mental health and psychiatry, and you can sort of see how difficult it was to make that decision. It was really hard.
Okay, so how did you get there?
Well, I mean, so I think after talking with that doctor, I talked with her. It was still a lot of back and forth. It was a lot of back and forth. But then one day I kind of just said, I'm tired of this sort of back and forth. I started talking to more and more, and I saw how mental health problems really were impacting the medical issues, the patients I was seeing more and more. I became more aware of it. And once I had my friend and saw his experience he had, I became more sort of open to the idea that it wasn't something that was just like a bad thing or something that only certain people could get. And so it really kind of opened my eyes to it. And I saw in particular how many of the Black patients that I was seeing had similar family stories as I didn't think of mental health illness as a real thing, and it really impeded their sort of general medical care. So I felt like I had a kind of a little niche after a while. And I also, last thing I'll say is that one doctor who told me I should be a pathologist or work in the lab. So I kind of took that to heart. You can always be sort of like, well, who does this guy know? But I kind of took it to heart. And I realized that maybe I wasn't trying to connect with people as way that I was. I was too focused on body parts and organ systems and all that stuff. And I started to talk to people more and spend more time. And I realized that it was kind of fascinating and people would tell you all sorts of things. And so it all kind of came together in that one day. But it was a really hard process. And so we're talking months and months and years.
Okay, so I'm going to pull you from a question that you don't address in the book.
Okay.
What'd your family say?
I think it's a great question. I think they were like, psychiatry. They were curious. They weren't like, well, my mom was, I would say. My dad was like, yeah, I could see that. You could be good at that. And so, eventually it all came together. And years later, I didn't talk about my aunt. I have my mom's sister. I didn't talk about her yet, but she actually had pretty significant mental health problems. I didn't understand at the time. It wasn't seen that way, but she later told me that she was really happy and that a lot of Black people really needed someone like me to be there and available to see them. And that's so it really came full circle, but it was a hard road getting there, because so much of the stigma that I internalized had really impacted me.
It strikes me that so much of how we think about these things is influenced by a few poignant moments. So when I read your first book, I had the thought that we had in many ways very similar backgrounds. We both came from kind of middle class backgrounds. I went to public schools. Did you go to public schools until I went to a private university? I think you went to UMBC in Maryland. But the main difference I thought in our backgrounds was that you came from a two-parent family and I was raised by a single parent. My father died when I was very young. But your experience in med school is completely different from my experience in med school. I went to the New York hospital had a psychiatric hospital. It was right there. We didn't have to go 40 minutes away. There were no prison signs. It was a private psychiatric hospital. People were very sick in the hospital because that is how you get into a hospital. I mean, psychiatry is the only field where the only way to get an insurer to authorize your admission is that it has to be a life-threatening crisis. If you're not saying you're going to kill yourself, you can't get into a hospital for depression. Unless you go to a private self-pay unit. But I remember even at the beginning of my career, an insurer asking one of the psychiatrists who was calling to say, I want to admit this patient, and the insurance company said, well, was the gun loaded? Can you imagine? Was the gun loaded? The person was holding a gun to their head, and if it wasn't loaded, we're not going to authorize the admission. In every other field, you can get admitted just because you're sick. But I trained in New York, and at the time, people were still interested in psychoanalysis, which in Baltimore nowadays, there's not a whole lot of interest in psychoanalysis. I live and work in Baltimore. So it was an expectation that if you were a psychiatrist, that you would go through your own therapy or even your own psychoanalysis. the chief resident, who actually gave grand rounds last week at Hopkins from when I was a medical student, would write on a chalkboard in the nurses' stations what times he would be in therapy so that you wouldn't call and bother him then. So it didn't have, what your book brings out a lot to me when I read it is this, you sort of talk about it, us versus them. I had this whole sense of other, that the patients are people who are other than me, and that psychiatrists are people who are other than doctors. And I think I grew up medically in a world that melded them a little more. Now, I will tell you that I did have one of my preceptors say to me, you're going to go into psychiatry? You'd help more people if you went into cosmetic surgery. There's nothing to do in psychiatry. But that was one person.
Oh. Yeah, I mean, so I think New York is the kind of epicenter, and maybe so there's definitely some differences probably than from where I was trained. You bring up a couple of different points that I think are really kind of interesting. I think this is, because even once I decided to do psychiatry, I still didn't. I think there was still something I didn't. I was thinking about more from like a kind of biological standpoint of and I still think there was still something I didn't really fully grasp the patient side of it. And I guess this is give you an example of kind of how important this is. A really kind of a life altering thing for me in terms of how I sort of see the patient care setting. So even though I'm going into psychiatry at this point, I'm still a medical intern. And so there's one night that I'm in the ER, and the patient comes in. He has this abdominal ascites. It's like he had a long-standing issue of alcohol-related problems and his liver failure, and so the swelling in his abdomen. So we have to do this procedure where you have to, it's called paracentesis, take away the fluid from his belly to sort of relieve the pain and distension. I had done all sorts of procedures throughout this internship year. Had gotten pretty proficient at them. I actually kind of enjoyed that. But this one particular day, I couldn't get things to work. And so I put the needle in, didn't draw any fluid back. I tried again, didn't work. And this is not something that ever happened to me. And then I started to kind of just get really frustrated, visibly frustrated. My resident told me, I'll take care of this, go another room, work with the student. And then when I went back into the workroom, and I kind of lost it. It was like 10 months of internship. I went to the workroom, had this clipboard, threw it across the workroom, started using all sorts of profanity, swearing, all sorts of things. And the student is the one comforting me. It's supposed to be the other way around. I'm 3-4 years up ahead of the hierarchy, and the student is comforting me, saying, it's okay. I have my sister's a doctor. I know how hard this first year is. And so then the next day, I had to go to the chief. I went to the chief resident because I was like, this might get out, that I did this sort of thing. The chief resident, so I'm thinking in my mind, I need to do some remediation as far as getting this procedure done. That's the kind of mindset I had. And the chief resident is like, I'm a little concerned about you. Maybe you're a little too stressed out. And before that moment, give me after third or fourth grade, I probably had cried a couple of times in my whole life. Once in like high school basketball related stuff, sports is so important to me. So one time when things didn't go the way I wanted to, I had to, you see those guys on TV after games, you can understand how intense it is. So I cried there once. And then my grandmother died. And that's all I can remember. But then this one day, this chief resident, the chief medicine resident, he tells me that maybe, he's concerned about me, and I just lose it. And I just start crying, and I'm like, I can't be, why am I doing this? I'm supposed to be strong. I'm a man, and I'm this, that, and the other. How can I be crying like this? And he says, I think you should probably go talk with someone, like a employee health kind of person. I had never done anything like that. Never seen any kind of counselor, therapist, never. I realized in that moment how different it was to be on the other side. So I had to go in there, and the next day or two, and for some reason or another, I wasn't dressed like this. I had on a sweatshirt, and I remember putting this hooded sweatshirt over my head because there was like such shame that I had to even the idea of like walking into a place where someone would say that I have a mental health issue. Like, how can this be, right? I've never thought of myself in that way. But then I realized, okay, I thought better of it because I'm a really tall black guy. If I walk into this place with this hooded sweatshirt, I might have other problems, right? We all know about that, written about that. And so I take the sweatshirt hood off, but I go into this room, and I see he was actually a licensed clinical social worker, and he was doing this assessment. And I realized in that moment, like how much power he had, or at least the power I thought he had, that he could like say I'm not fit to go back to work and I worked so hard to get here. He could say all sorts of things. And it was a sense of like powerlessness that was really profound. And it made me appreciate really for the first time what a patient could experience when they go and see you as a doctor. Because when you're an intern, you're only thinking, okay, you're thinking the world's beating you down because you're getting all these, you got to get calls from the ER, calls here, calls there. You think you're powerless. The system's beating you down, and it is. But at the same time, you still have tremendous power because that patient's there, the vulnerability that they have in that moment. And that was I was really appreciated. And so I've taken that with me from that day forward as I see patients, here and there, from every point forward. That was a really sort of powerful moment for me to sort of be on the other side.
There was an awful lot packed in that.
Yeah, it was a lot. It's a big story, man. Important, though.
I can work with that for a while. So I think the first thing that strikes me is that you were having a rough time in that moment in time. And the response of maybe you should take a little time off and talk to somebody and get some help actually was an act of kindness.
Sure.
You needed a break. You were melting down, but you saw it as punishment. You saw it as threatening, and oh my gosh, they're telling me I can't go back to work without talking to this social worker. It wasn't an act of kindness to you.
It wasn't the moment, but after I the thing was I talked to him and everything went fine in the end. And I was able to go back to work, shortly after that. But in the moment,
how many days off did you get?
A couple days, just a few days off.
Yeah, you got to sleep.
Yes,
and you got to sleep, and as an intern, sleeping's nice. You probably got a couple of good meals. Yeah. You might have gotten a little exercise.
Yeah, internship's brutal.
Helped.
Yeah, exactly. So what I do in the book is I talk about like what was I talk about like what was experienced then and what's the culture then and how might it be different now. So I'm trying to put this connected to the past and the present because I think a lot of the problems that we have when we're thinking about mental health and mental illness is how do we get here? It didn't just come out of the blue sky. There's been such a lot of stigma. And so I just told you kind of my story, but as I got to see patients, I would see things that were like, so much worse, right? There's I'll just kind of go on this other story. At this point, I'm in psychiatry. And again, just this idea of how different, how we see mental health and physical health so separately. You had mentioned in the beginning, you had mentioned earlier, like, you have a general medical problem, you come in with a left upper quadrant pain or whatever, right quadrant pain, you have appendicitis, something's wrong with your spleen, you get admitted, you have chest pain, you're gonna get admitted to the medical unit in most cases, right? If there's some concern that it's a potentially serious condition. But people come to the ER with mental health problems all the time, and it's not so simple. They can't just go upstairs to the unit because there's a total separation of how general medical hospital beds and mental health beds, and I saw this pretty starkly. So there's one so many things when it's a training you in the ER settings, and this is going to describe this case to the attending doctor. And he says, I'm starting to describe, when you're a trainee, you go through, you're all excited, this is a 37-year-old, blah, 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 and you want to go through all the sort of, the presentation. He cut me off, and he's like, stop. What's her insurance? What the medical issue doesn't really even matter because what her insurance status is going to determine everything. And it was such a powerful, like, a reminder, and it's easy to put him down, but he was actually right. Because there's a woman that one woman that I talk about in one of the chapters, where she comes in with she had taken an overdose, but not something that was going to be like immediately life-threatening, but it was an overdose, and so she needed attention, and she didn't have health insurance, and so we went to this dance of like, where can she go? Where can she go? Where can she be admitted to? And our unit was small, full. Other units, they don't have they don't say we can only take you because of insurance, but that's often what actually happens. And so in the end of the day, she had to go to the state hospital, that dreaded place for me in my medical school experience, and she had to go to the state hospital. And how does one get from a hospital, like a university hospital, to another hospital? So the first thought would be, ambulance, right? That's probably what you guys are thinking, right? But it's different with mental health. Not everywhere, but it varies from state to state. But in the state that I was in, the default was police. sheriff. And you guys have probably heard stories about how, this idea of like people have mental health crises, call the sheriff, call the police. I mean, the problems that can ensue from that. So you imagine someone, this is her first encounter with the mental health system. First time in her whole life, right? Ever encounter with the mental health system. And this is what happens, right? The police come to take you from one place. So it's like you've done something wrong, like you've committed this crime in some way, right? Why are the police taking you from one place to another? And so there's just such a powerful illustration of how we've seen these things as different, right? Now, a lot of that wouldn't happen now. So again, this is a terrible story from the past. And so I talk about how some of the things that are made that better, but this is a very real reality of how we've gotten to where we are. I mean, think about how sad that is, right? That the police is taking you from one place to another, and in my space, I'm here as a person feeling like I'm an agent, sort of complicit in that, right? So those are the sort of struggles and challenges that we face. And it's all kind of goes back to the history of how we sort of gotten here.
I struggled a lot with that chapter in your book. I think because I hate the idea that it was so awful to send her to a state hospital and it troubled you so much, because I feel like a state hospital is a hospital. It shouldn't be a horrible place to send anybody. The people, I mean, part of it is that it might be scary for a young woman who's just had an overdose, because the patients there might be scary. But it shouldn't be scary. It should be a hospital where people are comfortable and treated well, and the assumption should be that if you're sending this patient to a state hospital because there's not any beds anywhere else, that she'll get kind, humane treatment in the state hospital, and she'll come out. In our average length of stay in psychiatry is about 7 to 10 days. Is it still? It might be shorter than that now.
That's about right.
That in 7 to 10 days, she'll come out feeling a bit better. And as much as our average length of stay is 7 to 10 days, our medicines take 3 to 4 weeks to work. So it's not the medicines that are necessarily getting, I mean, some people respond quickly, but it's not necessarily the medicines that are getting you better in 7 to 10 days. It's actually the sleep and the rest and the break from the stress of your life, and the fact that you don't have to make your own meals. Somebody comes in, and anybody who's bothering you, you can put on a do not visit list. And often, I don't know if they still do this, because it's been a long time since I'm an outpatient psychiatrist, but they used to not let you have your cell phone. And just having not a break from your cell phone sounds wonderful. But I did struggle with the why is it so awful to be sent to a state hospital?
I think it was
it is,
part.
but it should be, yeah. And in Maryland, the police may bring you to the emergency room, but if you go from one emergency room to another facility, you're brought in an ambulance.
Right, exactly. And and I think that's amazing. So why would there be such state-to-state variability? Like, so in Maryland, it's that way, ambulance, and why would in this other state, North Carolina, the police? And so, I mean, think about, because police, I mean, so police coming to you to the ER, and then they don't just they put you in handcuffs. They put you in shackles. I mean, that's a completely horribly dehumanizing kind of thing to experience. So it was really
they don't do that to everybody in renal failure.
Exactly right. Exactly. And so that was a really kind of just like a really kind of powerful thing to be thinking about. Yeah.
You had me thinking in your chapter where you talk about your meltdown and the time off and the being assessed. You had me thinking about how we really don't define what mental illness is. That I bet if we asked everybody in the audience here what's mental illness, first off, half of people would be stymied, and the other half everybody would have a different answer. And I will tell you, I ask this every semester of my residents, and they're all like lost. You get something like, well, something that fits in one of the 300 categories in the Diagnostic Statistical Manual, but is having a meltdown as an upset resident, I mean, that's certainly not normal. We don't expect residents to get, or interns to get upset when they can't do a procedure and walk out and kind of throw their clipboard and melt down and start crying. But is that a mental illness or is that a meltdown? And where does that exact line go? And we certainly have definitions for it, but you kind of get into one of the definitions, say for major depression, is that it has to last 2 weeks. And if somebody walks into your emergency room or your office and says, I've been horribly sad the last week, I I don't have an appetite, I'm having trouble sleeping, I'm not interested in any of the usual things I like doing, I have no energy, I cry all the time and I want to kill myself. You don't say to them, sorry, it's only been 10 days, you need to wait 4 more days and come back. Right. You take what you have.
Right. So yeah. So there's certainly some, and I think that's one of the challenges with, and so there's sort of like a paradox. You know, one of the challenges is like, what is mental illness, right? And how subjective is it? And I think that's one of the challenges that psychiatry faces. And but again, you think about how very real the problems are that people suffer, right? So I mean, this is a little bit far afield, but I think one of the things that medicine is sort of allure of medicine is like numbers and images and scans. There's a whole discussion about how those things are not as nearly as perfect as we might want them to be, first of all. And I think one of the challenges with psychiatry is that if we go too far in the direction of trying to be too medical and too medicalized, we risk losing a lot. You know, and when we see patients, so I think that's one of the sort of the dangers that you know, that I've actually seen in practice. I also wanted to talk about language, like the language we use for mental illness and mental health, because you know it was commonplace for us in psychiatry to talk about patients, not in psychiatry, actually in medical school and medicine, to talk about patients, and not to their face, of course. It's nothing that it's no badge of honor. It's shameful to think about, honestly, but you might say, oh, this person is crazy in this room, or this person's batty, or this person's this person's that. There's sort of language that we would use. And think about the language we use when we think about some of the mental health, you know, the language we use, like addiction. So if someone has a addiction issue and we check their urine, it's clean or it's dirty. You know, that's sort of the language we use, right? We say someone commits suicide. That's the language we use. I never thought about it. I never thought about it at all. But you think about, you know, some people I think maybe I'm just being a stickler, but you know, you commit larceny. You know, you commit, you know, manslaughter. You know, so could we even imagine like suicide as something that's more like, you know, a stroke, you know, something medical versus a sin, right? I mean, can we even imagine that sort of concept? And so I think the language we use sort of informs how we approach patients in all sorts of ways. And so I think that's a lot of what I'm trying to, you know, work on and trying to stigmatize. So I'm laying out the challenge. We should at some point talk about like what's better and what are some of the solutions.
I think that in society as a whole, we've gotten very touchy about language.
Yeah.
You know, we talk about trigger warnings and safe spaces and letting people know. You know, you'll watch a TV show and it'll warn you there's sex, there's drugs, there's violence, there's suicide. But we also have gotten more sensitive. I remember in med school, it may be no worse than saying somebody's crazy, but you'd talk about the gallbladder in room 322, yep. Where the people in medicine have traditionally been pathologized. Mm-hmm. And I think we've gotten much better about, I mean, I have patients tell me all the time I'm bipolar, and my skin crawls. It's like, you know, you have bipolar disorder, and that's one piece of you. And the other piece of you is that you're a cat owner, a husband, a college professor, a physician. I see lots of people who, when they're not sick, they live completely normal lives, and their issues with mental illness are periodic. They're well controlled, but they do stay as a strong piece of people's identities. You never hear people say, hi, I'm a depressive. They say, I have depression. But they do say, I'm bipolar. I do think we've gotten better about a person with a heart attack, a person with a gallbladder problem, a person with bipolar disorder. And I think that's good. I really don't like defining people by their illnesses.
Yeah, I think one of the things with medicine is that the training process is very sort of, this is like, we think about how things we can get better, like what are some of the problems and how we can make things better. I think one of the challenges with the medical education model is that you see people only in their most sort of vulnerable, distressed state. It's important to do that, of course. You have to be able to manage that as a doctor. But I feel like in medical school, that's kind of the model. You're sort of in this cross-sectional thing. This person comes to you maybe in the worst moment of their life, and you're there. And if we think about some of the mental health issues, it maybe conditions you to think about someone who has alcohol use. You only see them when they're intoxicated or they're withdrawing, right? You don't see them as someone who maybe has alcohol problem, but actually is doing well or doing better. And I think the medical training model sort of does that. It reinforces that in ways that I think are troubling. And so a couple of years ago, so I'm involved with this course now where I'm trying to teach doctors who are not going to be psychiatrists about all the sort of things I think that are important that you miss just working in a unit. And so there was a few years ago now, a student was in that class, and he saw this woman in the inpatient psych ward, and she had schizophrenia, and she was very distressed and kind of all over the place, in all sorts of ways. But then 6 months later, we're in this place where I take the students to this it's sort of like a recovery clubhouse place where people have chronic severe illness, but they're learning skills, they're doing vocational training, they're taking classes, they're tending to gardens. And he saw this same woman that he had seen in the hospital, and then he saw her in this other setting where she was like functional, right? And he couldn't believe it. He was like in this, because people, I think there's so much of a conditioning. Like you think schizophrenia, you think this person's kind of always distressed, and he couldn't believe that this person was actually like, functioning, fairly well. And it was like mind-blowing to him, and he wrote this really fascinating, essay about it and how it really helped shift his experience. So I think a lot of the medical training model that we see is really based on this idea of seeing people only in their worst moment. And so how can we reimagine a setting where we can see people in a more whole way? And I think that's, not just even, it's true for like gallbladder, appendix as well, but it's particularly true, I think, for mental health issues where we can see the person, like bipolar disorder isn't just someone who's, the whole manic episode in the worst moment. It can also be a person in an entirely different phase. And how do we see that person in a more full way? And I think that'll really help us think about these issues in a lot different way.
I think Kay Jamison has done a tremendous job of spanning. I mean, she's a person who has bipolar disorder, who has written the book on bipolar disorder, or Ellen Sachs is a woman who's had schizophrenia and discusses her psychotic episodes while she's a law student at Yale and while she's getting her master's degree in England, and she now has a center at USC for mental health advocacy. I think she also became a psychoanalyst.
Yeah. So I think the challenge with those two, the challenge with those, I think they're great examples, and I write about them in the book. The one challenge is that they were both very sort of superpowers, very affluent, very highly educated. They're both white women, super successful. I think when people see like an average sort of like this particular case, this is a black woman who's not educated, not in this sort of fancy way. There's a real tendency to see that diagnosis and put it in a way that's very framed in a negative way, and that this person doesn't have the potential to do sorts X, Y, Z. So I think I do like both of them, and so I'm not disparaging them, but I do think that there's a difference in medicine about how we might see someone who's working class and is not sort of well off in that way. And so I think it was really eye-opening for me to sort of put students in positions where they can see people in a more full way. I think that's one of the things that we have to sort of think about when we're doing changing the medical model. Here's an example. Like think about even OBGYN. So you think about when we see someone, that affects everybody in many ways, right? When we see in a typical medical model, we see a pregnant woman when she comes to the hospital in labor. You got a doctor here. And then, we see her the next day after the delivery, and it's kind of like, well, have a good life, and that's the medical model. That's what you do, right? It's important to know how to do that stuff, right? But what if you saw that same woman when she was like, 16 weeks pregnant, and you saw her when she was 24 weeks pregnant, and then maybe you went through a delivery, and then maybe you saw her 6 weeks postpartum, and so you get a whole different idea of what it means to be a person. Like this medical encounter you have is important, but it's just one sort of snippet. Most people's lives are not in the hospital or not in there. So how do we help people think about things in a different way? So that's sort of the kind of work that I do now. That really helps people think about these things in a different way.
Well, I think, the wonderful thing about being an outpatient psychiatrist is, you talk about people that doctors see people as illnesses and when they're sick. And I have sometimes the opposite issue of like people only want to see me when they're sick.
Yes, that's true.
Most people don't. Most people see me, at a regular frequency. Right. It's not, it's certainly not every week for somebody who's well, but it might be once a month or once every 6 weeks or once every 3 months. And sometimes they'll start to say, like, why do I have to see you at all? I'm fine. And sometimes I do say, like, sure, if you want to stay on medicines, have your primary care doctor prescribe them. But But some of the people who don't want to come in get sick over and over. So I get called with emergencies.
Right.
And after it happens 2 or 3 times, I'll say to them, why don't you just do what everybody else does and come in, once every 4 to 6 weeks, even if you're well.
Right.
Which means that, because it's also occurred to me that I can't live my life with all day, every day being nothing but people in crisis.
Right.
I mean, it's very demanding and very intense when somebody's in a crisis. So I get the joy of being with people when they're well, and they're generally very appreciative of it. I think one of the concerns about going into psychiatry was, can psychiatrists do anything? Do they help anybody? People don't really get better. And that's
true.
just not true. People get remarkably better and are remarkably appreciative. And I think at a time of training of why would you go into that field? I found it phenomenally rewarding.
Right. Yeah. I think we could probably should take some questions, right? Yeah, got a good audience. Let's take some questions. I want to read a little passage before we leave, but we got some questions. There you go. Yeah, you're up, sir. Take a stab.
Yeah, I just wanted to, I guess, ask about, you were talking about language.
Yeah.
And, I think language frames a lot of our experiences, and a lot of times, at least I've seen in friends, and I guess even in myself, whenever I'm going through something that's rather difficult, sometimes the way that we can express ourselves we can be saying the same thing, but it can be in maybe a more harsh way, maybe a sadder way, maybe a more joyful way, whatever it may be. Right now, I seem a little bit anxious, I think.
You're doing fine, buddy.
I'm nervous.
You're doing fine, buddy.
But I could express this in a little, more angry or whatever it may be. And depending on how you express it, you can almost get put into a different box in psychiatry or just mental health generally. And I guess I'm just wondering, is that a problem with the boxes, or is that an actual problem with the person's health? That's something that I think about a lot.
Well, I think it can certainly be both things depending on the situation. I do think, to speak to the question about the boxes, I do think that it's something that is, it can easily happen. Medicine is so, there's definitely a tendency for people to be fast paced and particularly if you're not in urgent settings. And so one of the things that you're right, sometimes people don't communicate things the same way for different reasons. So one of the things that I often will tell trainees, students and residents, is that a lot of times when people make you feel uncomfortable, then you yourself want to kind of get out of that situation and you feel uncomfortable as well. And so I tell some people that sometimes that's a signal that maybe you should kind of slow things down, right? To slow it down. Because when you've had that desire to want to push away, maybe you should slow things down. Because when you feel that kind of rush, your rush, the patient's rush, things can kind of go south and people can get misdiagnosed and all sorts of things. And so I really stress this idea of kind of slowing things down in that moment. To make sure that you don't, that you don't sort of get people in that sort of box sort of thing. So I think that's one aspect of it. But thank you for that question. What do you, buddy?
Thanks. So you've talked how growing up in a black family that there wasn't a lot of awareness of sort of mental health and mental illness, and I think I identified with what you were describing. That rings true. I'm wondering, do you think that now or in recent times that the black community is becoming more aware of mental health, and do you think there are ways of trying to spread knowledge about this among black Americans?
Sure. So, there's certainly some, various celebrities have done various public health service types, things, Taraji P. Henson, and there's been other people who've done different sort of initiatives. And I think in some ways that certainly can be helpful. Certain athletes, professional athletes have talked about their depression openly, things that wouldn't have happened, 20, 30 years ago. So those things are definitely helpful. I would also say another thing I think is helpful is that there's been more of there's been alliance, increasingly so, among black churches in some ways and mental health providers. Historically, there was actually a lot of division between those two things. They're very separate. But I'm part of programs where people are sort of kind of bi-directional. So someone might see their pastor first, and the pastor might refer them to us, and vice versa. And so I think that's another way that's beginning to help with these things. But there's a long history that has led us to where we are now. So it's certainly not going to be fixed overnight. But I do see that those are sort of two things that I think are definitely making it a little bit easier for people to talk about. Yeah, great question. Other questions, thoughts? Yes.
Title of the book.
Yeah, so the question was about title of the book, Facing the Unseen. It's kind of like a little bit borrowing of it's a James Baldwin quote. I never quite get it right. I probably won't today. But it was an essay he was writing in the New York Times back in the early '60s, talking about the state of, it's still in the civil rights movement, and he was describing something to the effect of everything. You can't change everything everything that's faced can't be changed, but nothing can be changed until it is faced, right? This idea that you can't actually begin to address these problems. So the unseen here is the challenges that we face with marginalization of mental health within medicine, within society. Again, it's unseen, right? There's not lab tests, there's not, an MRI or scan that's going to show, well, this person has this illness based on that. And that's what we sort of love in this sort of medical world. But there's still its unseen quality, but it's a very real thing, right? It's very real. There's a lot of suffering out there. And so we have to kind of think about how can we face that unseen and how can we sort of center that within medicine. So so it's inspired a little bit by James Baldwin, but also by the idea of mental illness being unseen, but obviously very important for us to sort of really face.
Damon, I have to say I love the title because I saw it on multiple levels of, facing the unseen and the way you were talking about it. But it's, just on it, you can think about it on a societal level, you can think about it on an individual level. So I thought it was a great title. And I thought the subtitle did a good job in clarifying what it is we're talking about here.
Yeah. It's funny, just off the cuff here. So, both book titles sort of came to me when I was after taking a shower. I guess it's something, the shower is supposed to be to help your body, but I guess there's something about the mind too. I'm all about this whole mind-body thing, right? And so there's a certain clarity that kind of got from both. And just one day, they both just kind of made sense. I think I really appreciate your insights on that. Yeah. Any other questions?
I think we can do one more before.
Yeah, one more question. And I want to read this passage. Do you have a question, ma'am? I thought you had your hands up. There's a question. We got two here. We got a couple here. Maybe we can get these two, and then I'll read the passage.
So I was just curious if you have any thoughts about what can be done to make medicine and sort of recognize mental health as being an integral part of the care that you receive for your physical health.
I think we're seeing more, so what can we do to make it better? I think we're seeing some of those trends, right? So the idea that I have a course where I have the latitude to sort of teach medical students, and it can kind of give me free reign to sort of to structure as I see fit. Because 90+% of doctors are not going to be psychiatrists. But if you're a cardiologist or you're an orthopedic, whatever, surgeon or whatever, you're going to see people with mental health problems. And the training that you got in medical school really is not sufficient to help you with that. And so really what I try and do in these courses is really try to structure, how do you get more continuity? How do you see people as more whole? And so when you see someone with an alcohol-related problem on their chart, you're not just thinking this guy is a going to be a big mess, right? You're seeing, I've seen people who have alcohol problems who do well. And so you may think about it differently. Maybe I can have the skills to help that person. So that's one thing I see. I also see that a lot of the younger students I work with now, they have a language, they're more open about their own sort of mental health challenges. So I have students who've told me that they've struggled in med school and then they've seen therapists and it's helped them through there. So, and I know it's different in New York, but all I can tell you is that in my medical school world, if I would have told someone that I had a mental health issue, it would have been seen like weakness. I can just visualize what people would have been saying and thinking in the world that I grew up in, in the training. So I think there's a lot of changes that are happening from the younger generation of students who are more open to it, and also some curricular changes where now we're not just seeing people only in crisis, but we're also seeing people in a kind of more continuity space. So those are two things that are really helping. You had a question, sir.
Hi, Dr. Tweedy. I'm so happy to meet you, and forgive me for being late. The Uber took me to the wrong bookstore.
I was worried about that.
I'm in from Philly. I'm a New York actor, and I have a foundation, America to Africa Higher Education Foundation, where we assist brilliant Nigerian scholars keeping them in college. And a number of them are on the medicine surgery track.
Sure.
And they were thrilled that I was coming to see you today. I put you up on my Facebook page. So I think my question is, even though the thematic of your new book has to do with the disparity in America, is there a cross-cultural message where my students in Africa who are studying medicine are probably concerned about the overall difficulties in their country of Nigeria?
Well, I've seen a couple of different things there. So I've seen over the years, seeing medical students from, I think that's an interesting challenge because I've sometimes seen students who are in this country, and there's huge cultural sort of perspectives on what's mental illness and what's not mental illness. And I've seen some students sort of struggle to kind of navigate that, right, and think about that. But I will tell you that I've had many medical students in more recent years. Traditionally, when you think about cross-cultural medicine, you're thinking about things like infectious disease and OBGYN and pregnancy outcomes. Those are the things you think about first. But I've had more and more students in recent years talk about mental illness and mental health and how important that is in their country of origin. So I've really found that I really started to see an interesting shift. And again, it goes back to this generational thing that I'm seeing. So I actually am encouraged, actually. So because I think that's because again. And I'm going to be this passionate. I think that really will illustrate that. I think these things are really, as much as this physical part is important, the mental health part can't be separated from that. So let me read that last little passage here, and I think that'll put it all together. We'll sort of really put it all together. Oh, you know what? I turned 50 this year, right? So I guess that means, you know it. I think this really kind of puts it all together, kind of what I'm trying to say here. All right, here we go. 2 paragraphs. So body and mind and body. For far too long, we've drawn a sharp line between them. For patients, it often means seeing your general medicine or specialty doctor in one part of town and your psychiatrist or psychologist in an entirely different area. Or visiting the, quote, medical doctor on the first floor of a hospital or medical office and the, quote, mental doctor in the basement. For physicians, this separation has conditioned us to believe that, quote, body medicine is objective and clear-cut, while, quote, mind medicine is make-believe and less valuable. But as Doug, Willie, and so many others continue to show me each day I enter a hospital or clinic, there can never be a clear divide between our physical and emotional selves, any more than we can live without a functioning brain and a beating heart. These and other essential organs all inhabit one body that works in concert to experience all the joys and pains, all the triumphs and tragedies of this thing we call human life. The more we can embrace this ethos as we enact laws, build hospitals, devise health systems, and educate the array of future healthcare workers who will one day face us and our loved ones in our greatest hour of need, the better off we will all be. So, want to thank everyone for coming. Thank you, Politics and Prose. Thank you, Dr. Miller. Great to see you again. And thank you, C-SPAN. And thank you, everyone, for coming out here on a Friday night.
Awesome. Thank you everyone for coming. If you haven't, actually do one final round of applause. There you go.